Good afternoon, everyone, and welcome to our webinar today. Let's get to zero HIV. We have all the tools we need. Today, we're going to look at an overview of combination HIV prevention, HIV trends in the UK, and why new diagnoses have declined in the last decade. And then we'll be looking at the future and where do we go from here. And there'll also be opportunities for questions. If you can use the Q&A function to send any questions through, as the audio lines are muted just due to the number of attendees on the webinar today. Just want to quickly start off, for those of you who aren't aware of what the HIV Prevention in England campaign does in the country, and we've just to look at the current It Starts With Me campaign and the overview of the programme before we get started. So the HPE programme currently works in 4 different areas as a social marketing campaign aiming to influence behaviours of people around HIV prevention, sector learning and development, systems leadership, and local activation. So utilising other organisations, mostly community and voluntary organisations, on the ground to implement the activity of the programme to further influence the largely digital advertising campaigns like It Starts With Me. And the strategy is to inform, motivate, and enable people to think about the different HIV prevention methods available to them and what might be most effective for them to make use of. We target the key populations in England and the UK. It's a social marketing campaign, and the main promotions via digital advertising, mostly through social media channels, but also utilises other online advertising via apps and websites, as well as some outdoor print and in the media, particularly around our large campaign like National HIV Testing Week. We utilise real people in our campaign messaging and imagery, and that's all user tested with the communities that we're looking to influence and target. National HIV Testing Week runs each November, and just a heads up, this year it will start on Saturday the 16th. A large part of our campaign is targeting people towards the Starts With Me website, where people can utilise online tools to find out when they can test, which tests are appropriate, and also other information around other combination prevention methods. Our current summer creatives, a vibrant summary theme. We've utilised some of the same models that we used last year, just so people recognise the campaign. And HIV Testing Week for the past years has utilised the Give HIV the Finger slogan, and that's something that will be continuing this year as well. And just some examples of the targeted online promotion, print and out of home that we utilise to impact and make people more aware of the campaign outside of digital areas. And we also make the most of influencers and the media to help make an impact around the campaign, to increase testing and to increase uptake in the other combination prevention methods. If you're not aware, we recently launched our new portal, and that can be found at thtresources.org.uk. And the resources are free for anyone who's working in HIV prevention in England. If you've not registered your new account and had an old portal account, if you go to that site after the webinar, you'll be able to create a new account now. And at the moment, we're offering our summer activity, printed materials and merchandise. And obviously we'll be making sure that you're all aware of what's coming out ahead of Testing Week later in the year. And these are just some of the local partners that we've worked with over the years who make the campaign possible. So on to combination prevention. Largely when most people think about combination prevention, we're thinking of 4 main tools that we have to hand. And that's condoms, HIV testing, PrEP or pre-exposure prophylaxis, and HIV treatment. We all know that using condoms correctly and consistently protects people against HIV, STIs, and unplanned pregnancies. We know that sexually active people aren't always using them though, especially those who are within the groups most affected by HIV. From the State of Play Gay Men's Sex Survey in 2014, 61% indicated they'd had anal sex without a condom in the last 12 months. And in the African Health and Sex Survey in 2013 to 2014, 11.5% of respondents indicated they hadn't always used condoms during sexual intercourse. More recently, insights from the Kantar public evaluation of Our It Starts With Me campaign found that 37% of gay and bi men reported using condoms always or very often. 26% of Black African people stated the same. Increasing in efforts to normalise HIV testing since 2012 have been a fundamental cornerstone of HIV prevention efforts in the UK, largely because it's making people aware of their status, and if they're living with HIV, they're then able to uptake HIV treatment. With now more ways to test than ever before, expanding not only from sexual health services, but with community testing, testing in primary care, in high prevalence areas like A&E and other health care settings, for example, HIV screening during pregnancy. And obviously in the past few years in the UK, we've also seen a larger uptake of the self-sampling or postal testing, in particular PHE's self-sampling service around testing week sees a phenomenal increase in people looking to test that way, and also via self-testing, which has been legal in the UK since 2014, with the first kit being available since 2015. And last August, Superdrug became the first high street retailer to sell those home test kits, which further normalises testing amongst the general public. We know that people living with HIV on effective treatment can't pass the virus on to their sexual partners, and this evidence has been building from the past 20 years. However, we also know that public attitudes and knowledge are still falling behind the medical advancements. And just last week, Terence Higgins Trust released the results of a poll that they'd done with YouGov of 2,075 British people, which found that only 19% of them were aware of this fact. And furthermore, 48% of people would still be uncomfortable kissing someone living with HIV, and 38% would feel uncomfortable going on a date with someone who's living with HIV. And this is despite the fact that we largely know that most people are aware that you cannot get HIV through kissing or through casual contact. PrEP is the prophylactic use of antiretroviral therapy to prevent HIV infection by blocking the virus's ability to replicate inside a CD4 cell. And with numerous data from trials, including IPREX, PROUD, and IPEG-A, which have shown PrEP to be an effective method to prevent HIV transmission, there are access issues currently within the NHS in England, and the most way that people are accessing PrEP at the moment in the country is through the PrEP Impact trial, which is an implementation trial which has seen a high demand, especially amongst gay and bisexual men. We also know that people are purchasing PrEP privately via online pharmacies, and a conservative estimate on the number of people doing so is around 10,000 at the moment. Utilising these different methods, we are seeing a reduction in HIV transmission, and have done over the past decade in the UK, with maximising HIV testing, especially repeat testing, and allowing people to access treatment, or those who are negative to consider whether PrEP would be something that would benefit them, seeing a reduction in HIV transmissions overall. And this is further advanced by different behavioural interventions and continued condom use. There are additional factors to consider when it comes to combination prevention. It's not simply the 4 different tools that we have available. There's other things that come into play, such as mental health, drug and alcohol use, STIs, and other issues that might be pertinent to certain groups. For example, transgender health matters that might influence whether or not people test or decide to take PrEP, for example. And it's not just the tools, which is why we're seeing a success in the UK. It's the structural strengths that we have to our advantage. The NHS is a universal healthcare system that everyone can access, the human rights and freedoms that we have in this country, and also the high quality surveillance systems and how we respond to those. The HAR system from Public Health England enables us to obtain rich data, which can then help us respond with evidence-driven methods to help reduce further transmissions. And it's also about the combination of prevention approach. So the access and availability of things like condoms treatment and the availability of and normalization of testing. And furthermore, we've also got to our advantage more than 30 years of determined activism within the UK from the HIV community, people living with and affected by HIV, continuing to demand rights and access to these approaches. Current HIV trends in the UK. At the end of last November, when Public Health England released the latest data for 2017, it was announced that the UK had met the UNAIDS 90-90-90 targets. And that meant that more than 90% of people were diagnosed, on treatment, and virally suppressed. And this was huge news and much to be celebrated. We now know that 92% of people living with HIV in the UK are aware of their status, that 98% of those are on treatment, and 97% of those are virally suppressed. And obviously, the fact that these people are on treatment and virally suppressed is good for their own health and their long-term health, but also for the health of others, knowing that because of this fact, they can't pass the virus on, and therefore we're seeing a reduction in transmissions. And we've seen this happening over the course of a period of time, but it's really since 2015 where we've seen this steep fall in new diagnoses, as you can see on this graph here. And at the same time, because of the access to treatment in the UK, you can note from the blue line at the bottom here that the number of deaths really has stayed the same. And this means that people living with HIV are living into later life and living longer. And that in turn means that at the moment, around 38% of people living with HIV are aged 50 and above. And obviously that brings with it different complications and different things to be mindful of. As people are living older, they're more likely to have other comorbidities, and it's impacting the types of support services that are needed for people living with HIV and what needs to be made available to them. When you look at new diagnoses over the past few years, specifically by exposure group, you can see that overall the trend has largely been falling. However, amongst gay and bisexual men, until 2015, there was actually a slight increase in new diagnoses until we saw this steep fall. This is largely down to the numbers of people testing, and we can see on this graph here the numbers of gay and bisexual men testing for HIV at specialist sexual health services who've had a previous test within the same clinic. And in particular, the numbers of people testing who'd had no test in previous 2 years has increased, but also those who simply had 1 or 2 to 3 tests in the past couple of years, or 4 more, has also increased over the years up to 2017. And we know that repeat testers are more likely to test positive, and this is largely why we saw an increase in new diagnoses. The proportion of people with a CD4 count of 350 cells or less at diagnosis initiating treatment within 91 days, we've seen a slight increase in most groups in recent years. There was a slight fall amongst Black African heterosexual men between 2016 and 2017. This increase is more noted in those with a CD4 count of 350 or more at diagnosis. And this has largely stemmed from NHS England's decision to commission treatment upon diagnosis in order to prevent further transmissions, which then more recently been extended to everyone living with HIV, no matter whether there's deemed to be a risk of onwards transmission or not. And this is where we've really seen a large increase from 2013, where most groups, around 30% that fell into this CD4 category, were provided treatment, to now between sort of like over 60 to 70% of people starting treatment within 91 days, which is obviously helping to reduce new transmissions. So is it all good news? The answer is not totally. Late diagnosis rates remain stubbornly high at around 40% for the past 5 years. And in 2017, 43% of people were diagnosed late. That percentage figure is highest amongst Black African men, where 69% of them were diagnosed late in 2017. In terms of the bulk of numbers, gay and bisexual men still make up the largest number of late diagnosis. And Public Health England have repeated their warning that people diagnosed late face a 10-fold increased risk of short-term mortality. Specifically looking at gay and bisexual men living with HIV who were diagnosed late, there is a breakdown amongst ethnic groups, with Black, other and Asian gay and bisexual men most likely to be diagnosed late at 36%. And this obviously has implications in terms of when we're targeting gay and bi men, who we're testing, and when we need to look at what groups we need to focus on. This data provides information on 1 year mortality per 1,000 among adults newly diagnosed with HIV by their CD4 count at diagnosis. And we can see here that those with a CD4 count with less than 350, the biggest factor that comes into play is their age. So again, that's something that we need to consider when we're targeting different groups of people, that we need to think widely across the spectrum of gender, age, ethnicity, and exposure route in order to reduce late diagnoses. Beaver conducted an audit of late diagnoses in 2016, and this table provides data on 773 individuals who were diagnosed with advanced HIV, and what they were doing was determining whether or not there had been missed opportunities for diagnosis, and also where these people had perhaps been within the health system prior to diagnosis. And you can see in the top right that large percentages had been either inpatients or outpatients or attended their GP and hadn't been diagnosed. Therefore, it was very unlikely these people were offered or decided to take an HIV test, despite the fact it's very likely they were living with HIV unknowingly at the time. And in fact, the audit found that there were 257 missed opportunities documented in people's records, and a further 100 was identified as part of this audit. And this really plays into the fact that we should be following the guidance and quality standards when it comes to testing, which we'll come on to. So this is the picture of where we are now. Where do we go from here? A priority for prevention efforts in the UK for the past decade has largely focused on gay and bisexual men, or men who have sex with men, and Black African men and women. And both these groups make up 70% of people diagnosed in the UK, but also 75% of those still undiagnosed. However, the latest data from Public Health England has indicated that there's benefits of increasing HIV prevention efforts towards people who are born in higher prevalence countries. And this is a slight nuanced change in just thinking about Black African people and thinking about other populations or populations within people who were born in Africa in specific countries. We've also seen across the HIV sector, there's been an increase to engage trans and non-binary people in HIV prevention. The data we have on this population remains incomplete. However, Public Health England have advised that not all clinics are currently using the latest HARS system, where they're able to populate different types of genders other than just male or female. And so until that system is implemented across the nation, we'll have an incomplete picture. The numbers of new trans and non-binary people being diagnosed remains quite low, with around 8 new diagnoses in 2017. In terms of how we can use the combination prevention approach and increase access and availability, an analysis of our It Starts With Me condom quiz in 2017 found that only 14% of people using the tool were satisfied with the condoms they'd been using. And largely the reasons why people weren't happy was that there wasn't enough sensitivity, they were too tight or too short or too loose, or they were itchy, which was a potential sign for latex allergy. Just over 3,200 individuals went on to order free sample packs at that time, and the different types of condoms ordered matched the responses given within the tool as well. So a lot of people, 50%, were ordering extra sensitivity sensations condoms, followed by large, trim or smaller, and latex free. And so it's really not enough just to provide access to condoms. We also need to think about the different types that are available and ensure that there's a range of types that could benefit different people, especially if they're having problems with the ones they're using already. With regards to increasing testing, this really stems from NICE guidance from their quality standard, which is 157 from September 2017. And some of these quality statements we know are happening. So, for example, statement 5, people who may have been exposed to HIV by a person newly diagnosed with HIV are offered an HIV test, we know that the partner notification route offers one of the highest positivity rates of any testing initiative in the UK, and that is largely being done by clinics. However, there are some where we're still falling behind. So statement 2, which looks that HIV tests are offered in GP practices when registering, or if they're having a blood test, is still too low. And in these high and extremely high HIV prevalence areas, we still need to be working more with primary care professionals to ensure that they're adhering to these guidance and that they're thinking about implementing them in their areas. And I've just had a question around the Condoms by Post initiative, which is a Terence Higgins Trust initiative. And is that just for Scotland? And yes, that's correct. We offer certain services in different areas, and the Condoms by Post one at the moment is just specifically linked to that nation. Another means to increase testing is around self-testing, which we now have available to us. And Terence Higgins Trust has conducted a number of self-test pilots. And in 2018, thanks to funding from a legacy, we're able to initiate a free programme for a limited period of time. And during those programs and that pilot, over 31,000 test kits have been dispatched in the UK. 60% of people reported results to us. 11% of them used a click and collect service where the test wasn't delivered to their home, but to a point up to 4,000 different locations in the country where they could go and collect that package discreetly. And 122 reactive results were reported from it. And one of the points from the click and collect service we found was that it was utilised by those who often test less often than other groups or are less susceptible to testing. And in particular, heterosexual Black African men and also Asian and Chinese gay and bisexual men were using that click and collect service and potentially testing for the first time. And we also had a high uptake seen in rural areas where we know clinic access to testing can also be an issue compared to city locations. This data from Public Health England is the current estimates of the numbers of people living with HIV, whether diagnosed and undiagnosed. And one of the real challenges facing us now is that this number of undiagnosed people is now down to 7,800. And this makes targeting those people, those groups within the population all the more harder, both logistically and financially. So whereas a few years ago, we were looking for thousands of people within particular groups. Now, for example, amongst those undiagnosed, just 1,500 Black African men and Black African women fall within that number. And this means that it's more work for the systems in place to locate and find these people. And we need to think smarter about how we do that. We can see from the data and looking at different population characteristics who are the largest groups that can be presumed to be still undiagnosed, looking at different age, looking at where people were born, ethnicity, and where they're located within the UK for both gay and bisexual men and for men and women. And what this Venn diagram is showing here is that looking at the varying degrees of positivity amongst different populations. And what we can see here is that actually we're seeing highest positivity rates in 2017 in sexual health services, where people were both Black African heterosexuals who were born in a high prevalence country. And we're also seeing a greater number of people who were born in other high prevalence countries who were not Black African, compared to those who were Black African not born in high prevalence countries. And regarding those countries, largely there's still most of them are within the African continent in sub-Saharan Africa. However, we are seeing other emerging populations, and the underlined countries and asterisk countries here are those where there were 10 or more people diagnosed with HIV in the UK in 2017. And in particular, if we look at Jamaica, Russia, and Thailand, they're countries which we've largely, the systems haven't targeted, haven't looked to explore or speak to about testing initiatives or other prevention initiatives today. And it's something that we should be thinking about. We don't have a breakdown of this data though, so behind this, other than the fact that we know these are the countries where we were born. We don't know people's sexuality or gender identity, for example. And we'd need further information for us to make some more informed decisions. We know from the information that I described earlier from Terence Higgins Trust's most recent poll they did with YouGov that we need to increase knowledge around treatment as prevention. Prevention access campaigns, undetectable equals untransmittable, global community now spans more than 850 community partners and is in 100 different countries. And working with the media and around public awareness campaigns, we can improve knowledge. So I mentioned earlier that just 19% of Brits were aware of treatment as prevention, but 2 years ago when this question was polled, it was just 9%. So we know that we can have an impact and we can update people's knowledge, which in turn reduces stigma and which reduces barriers to testing. We also need to increase access to PrEP and awareness of it. So the latest update with regards to the impact trial, NHS England have recently announced they would support an open-ended additional places on the trial where any clinic or council would like them. The demand for PrEP has largely been from gay and bisexual men, and we need to increase efforts to reach other groups. There are some great initiatives out there already from organisations like PrEPster and I Want PrEP Now, and Public Health England Innovation Fund have funded many different groups and organisations to come up with new initiatives. And one of the latest ones is PrEP and Prejudice, which is being led by the African Advocacy Foundation and launches later this month. And we really need to see these efforts increased if we're to really utilise PrEP to its maximum effect and not just letting it be seen as a prevention method for gay and bi men. So there's many challenges and opportunities ahead, and it's great that we've reached the UNAIDS 1990 goals ahead of the target. However, reaching undiagnosed people with HIV will become more difficult logistically and financially as the numbers get smaller and we get closer to zero. There are a number of different ventures helping us to reach this goal now, so as well as our programme and the London HIV Prevention Programme, which some of you may know as the Do It London campaign. There's a growing number of fast-track cities across the UK signing up to help reach zero transmissions. But for us to do this, we need to ensure that we're upscaling existing testing initiatives, including self-testing, and robustly implementing guidance and quality standards. We need to ensure that local and national data continues to drive evidence-based HIV prevention methods and targeting, that we're engaging all communities affected by HIV in the benefits of PrEP, and we need to ensure that we don't leave behind rural and smaller urban areas as fast-track cities emerge to grapple new transmissions in the larger urban locations. And finally, we still need to work cross-sectorally on the cooperation to tackle HIV-related stigma, which we know still continues to be a barrier around HIV prevention, not just those living with HIV, but ensuring that people test as well. Thanks for joining us today, and if you have any questions, feel free to send them through now. And just to let you know, we have another webinar coming up on the 24th of July, and we're being joined by Dr. Rageshri from BARTS and the Public Health England STI surveillance team, and we'll be looking at HIV and STIs within BAME populations. So I've had one question through asking who the fast-track cities are. So currently, those who are involved and who've progressed some way, the first city to sign up in the country was Brighton, followed by London. Manchester and Liverpool have recently joined, and Glasgow and Bristol. And I understand there are a couple more cities who are thinking about signing up to the initiative. This is really led by local councils in partnership with local community organisations, local NHS systems deciding on what they want to do. And in some areas, the fast-track cities are being funded by those systems, funded by local government, and in others, they're seeking funding from other ventures in different means. So the fast-track cities are all in different positions at different spaces. It's a global initiative. There is a fast-track cities conference being held in London this September, if anyone wants to know further information regarding that. And I've had another question. So what has been the cause of low HIV awareness campaigns of late? And I think a lot of this is probably due to the funding situation within the sector at the moment. So we know there's been a lot of cuts to public health campaigns and public health money. We know that many organisations that work within HIV and sexual health are struggling to make ends meet. And this obviously puts a pressure on the amount of activity they're able to do. I think there have been some really exciting campaigns over the past year. GMFA's Me, Him, Us campaign was a great campaign that was targeting testing amongst BAME, gay and bisexual men, particularly Black gay and bisexual men. And they're going to be extending that campaign to South Asian gay men later this year. But all these are reliant on external funding. And I think that's the major issue there. Okay, if there's no other questions, we'll finish there today. Thank you everyone for joining us, and do put that next webinar in your calendars. We will send out invites to sign up to that at the end of this week. Thanks.